Good afternoon, and thank you all for joining us today. My name is Anton Gunn, and I'm an advisor to The Intersection, a Robert Wood Johnson initiative with a focus on leaders in advocacy in healthcare. And a special welcome to those of you who are joining us for the very first time. We're happy to have you here. See, The Intersection is a place to convene, to learn, to share resources, and discuss what organizations are doing to build anti-racist healthcare systems. This is a community that encourages collaboration with others, and it's a place to get real about what is and what isn't working to help you to develop effective strategies for your efforts. So please check out our website at meetattheintersection.org to access recordings of previous conversations, resources from the Robert Wood Johnson Foundation and their grantees, short videos from equity leaders. The website is packed with valuable resources. And there's also a podcast called The Intersection, where healthcare and anti-racism meet, which is available on all streaming platforms, wherever you like to listen. And if you've not signed up for The Intersection's LinkedIn page, please do so. You can connect with others, access interesting stories, and stay up to date about the future events and resources that we have available. So today, we're here to discuss reproductive justice in action. Not just reproductive justice, but reproductive justice in action, and how it can help us to deliver equitable outcomes and real solutions to the maternal health challenges our communities face. Building community with others committed to reproductive justice is essential. I've worked in a variety of capacities, including as an organizer and advocate. I've been a state policymaker, and I've been a chief diversity officer for a health system. However, the most rewarding position and role in my life is that of father and also husband. Although I have a very healthy daughter now who's in college, her experience coming into this world was not the smoothest. As a matter of fact, my wife's wishes for her pregnancy were ignored, and her worries were invalidated. These experiences left us with trauma, unnecessary trauma. And that's why this conversation today is so important. Reproductive justice means that every person has the right to body autonomy and privacy, to have children or not have children, and parent children in the safest and the most sustainable communities that they live in. However, for some people, reproductive justice is out of reach. Last year, more than 1,200 people died in the United States due to complications related to pregnancy or childbirth. More than 80% of those deaths, almost 1,000 people, could have been prevented, according to the CDC. Now, Black and Indigenous women are 60% more likely to experience preterm birth, and Black women are 3 times more likely to die during childbirth than other races. We can't reverse these trends without addressing the structural racism that exists in healthcare settings, the lack of access to coverage, and the absence of culturally competent, respectful, and compassionate care. So today, we're not just naming the problem, we're gathering the power and the passion and the wisdom to build something better. By uplifting voices from our communities, honoring the lived experiences, advocating for care that is respectful, and ensuring that women have options, we can reimagine and build a maternal health system that works for everyone. And it's not only in recent history that reproductive care it's only in recent history that reproductive care is hospital-based and physician-led. And that's right, it's necessary for some people. But for many people, a birthing center or a midwife is better. Whether in a hospital, whether in a birthing center, or at home, a doula can help women make informed choices, advocate for their wishes, and support them before and after birth. So I'm excited for today's discussion, and I hope that we all can walk away more knowledgeable and more inspired to join the reproductive justice movement to improve healthcare outcomes for all. Now, before we dive into this great discussion that we're going to have, I got a couple housekeeping items for all of you who've joined us. Number one, please add your questions into the chat throughout this discussion. We're going to record a podcast after today's panel, and based on your questions and some of the themes from today, we will weave those into a conversation. So I hope you will stay also for the breakout groups. That's the second thing, the breakout groups. These are an opportunity to continue the discussion and meet others that are doing this work. So if you plan to stay for the breakout groups and you need to be in a room with an ASL interpreter, please send a private chat right now to event support. I'm going to repeat that. If you plan to stay for the breakout groups and you need an ASL interpreter for support, please send a private chat right now to event support. Okay, so let's get into it. Now, I'm grateful to be in this conversation with an incredible panel. Each speaker brings an expertise shaped by their deep knowledge and shared commitment to advancing reproductive justice throughout culturally responsive, community-centered care. And first, we have Jamarah Amani. She's the executive director of the Southern Birth Justice Network, co-founder of the National Black Midwives Alliance, and a founding member of the Queer and Transgender Midwives Association. Jamarah currently leads the mobile midwife clinic in Miami, providing midwifery and doula care to South Florida families in a converted RV, and the Miami Birth Justice Initiative, which works to transform hospitals to center birth justice. Now, our next speaker is Chanel Porchia-Albert, is a prominent health policy advocate known for her transformative contributions to reproductive and maternal health equity across city, state, and federal platforms. As the founder and president of Ancient Song and the co-director and director of equity and program strategy for JustBirth Space, Chanel has led vital policy advocacy initiatives to address racial disparities in maternal care, advocating for Black and Latinx communities and championing reproductive justice. And our third speaker is Leseliey Welch, the co-founder and board president of Birth Detroit and the chief executive officer and co-founder of Birth Center Equity. She has nearly 2 decades of leadership experience in city, state, and national healthcare organizations. She served as the interim executive director of Birthing Project USA, deputy director of public health for the city of Detroit, and consulted in the development of Michigan's first comprehensive LGBTQ health center. So as you can see, I'm the weakest in this group. I got some superstars here today. And so I want to jump in and get started. So Jamarah, I'm going to start with you to level set a little bit. What are some of the historical and systemic factors that have contributed to the current maternal health crisis in the United States, especially as it relates to the disparities faced by Black women?
Well, Anton, thank you so much for having me today for this conversation. Really excited to engage with my sisters here. This is stuff we talk about all the time and been talking about for years. So happy to bring this conversation to this space, and greetings to everyone. So the history of perinatal health in the United States is really intertwined deeply with racism and white supremacy. We know that our ancestors, particularly as Black people, our ancestors that came to these lands forcibly brought with them traditions of health, of healing, of culture, and that there were many midwives who were brought across those waters. You also have, rooted in these lands, in these stolen lands. I'm in Miami, Florida, in Tequesta land. You have indigenous midwives who had their own birthing practices. And even throughout colonization and slavery, it was largely those women that continued to care for their communities in those traditional ways. However, in 1857, the American Medical Association decided that midwives were somewhat the enemy and needed to be sidelined. And so they began a campaign to discredit those very capable, competent, well-trained, and generationally trained midwives, and to paint them as uneducated and dirty, and really make it so that people, particularly white women, wanted to have their care with relatively new profession of obstetrics, right? It was just a burgeoning profession in the late 1800s and early 1900s. And they were really experimenting in a lot of ways. And Black midwives were the primary healthcare providers for most people, especially in the South, including Black and white people, and did so very well and, had great outcomes. However, they weren't tracked in the way that we have now. But we know anecdotally that there was, rarely mothers and babies lost, not in the ways that we see today. And so when birth moved into hospitals and obstetric care, became a thing and perinatal care moved into clinics, we started to see that that was an opportunity for primarily white male doctors to control women's bodies. And we saw the experimentation on Black women's bodies by the so-called founder of gynecology, J. Marion Sims, right? Experimented on
Mhm.
what we call the mothers of gynecology, Anarcha, Betsy, and Lucy. And so we call their names because we want to remember the Black women's bodies on which obstetrics was founded. And what that did is it really moved people farther away from community and from the center of care being in the community. And that care moved into institutions. And then as that happened, they began to outlaw the midwives. And so we
Mm.
have now a situation where we still today have states that do not have legal home birth midwifery. Even though we have seen more states passing it, it still is a fight in many areas. And to get the Medicaid coverage and the birth centers and, to get a fully functioning maternal health system, we're going to have to fight our way back to that.
Wow. Well, I thank you so much for giving us that backstory and history. And as a South Carolinian, I know the story of J. Marion Sims, but not too many people do in this state. Chanel, I want to ask you to discuss your work at JustBirth Place and your partnership with Montefiore Hospital, providing trauma-informed physician training and to other providers. How has this helped to address some of the systemic failures that we just heard about that have existed in maternal care?
Yeah, I think one of the biggest things that we try to emphasize at Just Birth Space is accountability, right? And so within the framework that we've seen historically, there's been a lack of accountability, especially for communities and towards communities of color, and the ways in which they are interfacing with maternal health infrastructures, how they're able to access reproductive health care, especially when we're talking about, urban, whether you're in an urban, rural, Midwestern town, we find ourselves in spaces that when there is a maternal death, there is no form of accountability, right, to the community or to the family. When there is a birth trauma that occurs, there is no form of accountability
Mm,
to the families. So Just Birth Space really works with Monty to um, work with the residents, right? So
mm,
like before you get into a space where you have now really been entrenched in a framework that we know is hostile to Black women and birthing people, to indigenous, to undocumented populations, we want to combat that from the door, right? And so we're bringing in a birth justice framework. We're teaching them about what does it mean, not just from a theoretical perspective, but also what does that look like on an actual labor and delivery floor? How do you mitigate a situation before it gets to a point where someone is now experiencing birth trauma? How do you interface with community and create connection in meaningful ways, right? Where community stakeholders are active participants in the design of the care that they are receiving. And so, we have been working with Montefiore for going on 2 years now. We've, interfaced with hundreds of medical residents to really be able to bring this to them, but also to go and say, all right, now that we're with the residents, what does it look like for us to be with nurses? What does it mean for us to be a touch point for administration? And the great thing about Monty is that the hospital admin has been very open, right, to
mm,
wanting to solve some of the problems that they have seen, right? Because the Bronx. If anybody knows about the Bronx, and I'm gonna say it with the accent, the Bronx. If you know about the Bronx, then you know that it is a melting pot of various different ethnicities, nationalities. It is people who are coming from different socioeconomic um, standards. And so we really want, again, we want to hit it like right on the nail. We don't want to wait till after something has happened where we're trying to change a whole infrastructure while also trying to educate community, while also trying to change legislation. It's like, how can we be that touch point? And that's what we've been doing at Monty, really trying to, again, bring in that accountability framework that is non-punitive, right?
Mm,
Well, right? Because what we've noticed is that there's a hesitancy among physicians and others that we're going to come in and we're going to point the finger and say, well, you did this, right?
mhm,
So the first
mhm.
couple of months was really like pulling teeth and
Yeah.
trying to get people to really like want to talk about what they were experiencing as physicians trying
Mhm.
to do their work. And now, we have a very, very good working relationship with the residents that are there in the program. Um, and they're asking questions, right? They
Yeah.
are introducing a birth justice framework onto the floor. They're incorporating it into their work. They're looking at what does birth trauma look like from its inception before it begins, so that you don't have people who are afraid to give birth.
Very good. Well, I'm so glad that you elevated the context of accountability not being punitive, because sometimes we hear that word and we use it in contracts where we want to really hold people accountable. But in this respects, you are framing it up. It's about owning the responsibility of good outcomes. So accountability is about owning the responsibility that we all can do something, particularly from a clinician resident standpoint. They have a responsibility to help ensure the good outcomes, which requires them to be informed and engaged. So, great point to elevate. Now, Leslie, I want to jump to you as the co-founder of a birth center and someone who's actually worked also in public health. What are some of the opportunities that exist that you think that we can improve the culture of birth and how it can be changed for the better?
Thank you, Anton, for that question. I love it. And first, I'll say a couple things. One is birth is not a medical emergency.
Mm,
Two is there is nothing inherently wrong with Black, Brown, and Indigenous bodies. And sadly, we have created a culture of birth that is medicalized, that is physician centric, that is physician led, and that is hospital anchored and
mm,
historically rooted in a hierarchy of human value, whether that is families based on race, gender, attraction orientation, or class, or providers based
mm,
on credential. And what we advocate for and see an opportunity for at Birth Center Equity is a birth culture that is family centered, that is midwife led,
mm,
that is once again anchored in community, and that honors the inherent value in all people, right? And
mm,
we center birth centers because birth centers are the only healthcare facilities that center the midwifery model of care, not because birth centers are the only place that midwifery care can happen. And we know that birth center care improves the birth outcomes we say we care about. It increases breastfeeding rates, autonomy and respect is improved, and it comes at a lower overall cost to families and our health systems and our payers. And yet, this is one area of medicine where we allow ourselves to ignore a whole body of evidence that tells us to do things differently. And so I think we have the opportunity to reshape how we do birth in the United States for the betterment of our overall community health and wellness.
fantastic. I could double click and triple click on everything that you just shared there and what you all shared. But I want to like really help like tease this out in a way that I think would add value. Because let me just be honest. As a former hospital executive. I'll never forget this conversation. There was some data that showed that we had a disproportionate amount of low birth weight babies that were born in our community. And the conversation started to evolve around what could we be doing prior to, quote unquote, as you framed it up, that birth is an emergency, but prior to all of that. And I'll never forget hearing a physician say that what happens before they come to the hospital is not my problem. And it was a very, he was a solo person who had that opinion. Not everybody had that opinion, but that might be a mindset that some people have. So what I'm interested to hear from all of you, have you encountered, the context of institutional healthcare clinicians or leadership who feel like their job is just to deliver a baby when they get there, and the goal is to make sure there's not a bad outcome versus the ideal optimal having a good outcome. What's your reaction to that? And give me some context of your experience in that. Chanel, I'm gonna have you go first, and then Jamarah,
Okay.
you next.
I just was watching all of our faces because I think all of our faces were saying the exact same thing. And anybody who knows how to read a face who is on this knows exactly what we're thinking right now. But yes, we all, all of us have encountered this, right? From multiple touch points where, you know, where people feel like, oh, my only responsibility is to a good birth outcome. My question is, what defines a good birth outcome? A good birth outcome is not just a healthy infant and a mother or a parent who has not had any kind of medical complication. It is also about how they felt they were humanized within that experience. And it's a constant dehumanization and disassociation that we continue to perpetuate as members within a larger human society that also puts us in this continual and perpetual pattern of, well, that's not me, that's not my problem. Or well, that only affects this group of people. And so, that's their issue for them to figure out. And that's not the case. Well, and again, we have continued, and when I say we, I just want to be able to make sure that I'm defining we, and I'm very clear about what I'm saying. When I say we, I'm talking about we as human beings. I don't care if you black, white, yellow, purple, where you come from, how you identify. This level of dehumanization and disassociation is killing us. It is killing all of us. It doesn't serve anyone at any given moment. And it is that same level of divide and conquer and disassociation that allows us to continue to perpetuate harm and say, but I didn't do that. That wasn't me. And my hands are up in the air, right? Or to see a community that may be struggling and say, well, that is them over there. Or to see Black women and look at us and only see us as vessels of either life bearers or saviors of some sort, or individuals who have to always be giving of oneself in some kind of way to care for others. And it's not to say that we don't do that in some way, shape, or form. We all do. We are all caretakers in every point in our life. But that means that as caretakers, we need to really look at ourselves. We need to look at how we continue to dehumanize ourselves on a daily basis, right? And see how that is directly or indirectly perpetuating harm. And that also goes with de-siloing the work. Like we can't, there's an initiative here, there's an effort here, there is a conversation that happens over there. And we're never gonna get anywhere, especially within this maternal health landscape, if we keep having this fragmented peace of mind. It's not to say that different things don't happen in different ecosystems. It's not to say that there aren't more factors that may be associated in one area than another. But what it means is that how can we intrinsically learn from one another so that we don't have to continue to perpetuate the same harm and those same systems that Jamarah mentioned, which we know as white supremacy, like it thrives off of disconnect. It thrives off of disassociation. It thrives off of dehumanization. So if we continue to allow ourselves to feed into that, then we too are perpetuating white supremacy. We too are perpetuating that same harm indirectly or directly.
Wow. Jamarah, please add on to that. I see you snapping. Go ahead.
Snapping for Chanel. Yes, just to keep building on the beautiful brilliance that my sisters are sharing. This is really about our human rights. And when we look at the overall perinatal healthcare system in the United States, it's abysmal. I think we fall around number 60 in the world and definitely below any of the other, industrialized or, first world nations. But we're spending more money than any other country. And that has a lot to do with the over medicalization of prenatal and birth care. It has a lot to do with the training of physicians. It has to do with the midwives being pushed out of the system, obstetric violence, being kind of the way things are taught, informed consent not really being put into practice, unnecessary interventions such as C-sections, and the lack of preventive care, which is, I think, what Brother Anton, what you were referring to in your question, a physician saying, well, that's not my problem. What happens before they get here? Well, then that means that we're not preventing the complications, because if you have someone walking in preterm labor, or you have someone walking in with preeclampsia, and we know that 80 to 90% of those complications are preventable, that means that the necessary things weren't being done in order to prevent that person walking in the door with that complication, right? And then you have what happens in the hospital, which is a lot of institutional oppression and for-profit motivation, instead of person-centered care. And so what we're advocating for in the birth justice movement, and we, at Southern Birth Justice Network, we've been working on building this birth justice movement since around 2009. And we have the Birth Justice Bill of Rights, which I know was shared in the chat. We have our Miami Birth Justice Initiative, which is largely centered in South Florida to address local hospitals by utilizing leadership development, promoting self-determination, and building community power. To really create a more equitable and just healthcare system that leans into accountability instead of leaning away from it, and that centers the values of birth justice and the human rights of all birthing people. So for me as a mother, I'm a mother of 4, and I've given birth in a hospital, and I've also given birth twice at home, right? And so I can tell you from my own experience, the vast differences in those two care centers, and also the providers that I had access to. When I had a midwife, I had a sister, I had a mother, I had someone to really hold me in the process. When I had a physician, and a nurse, I had coldness, I had sterility, I had a feeling of loss of power. It's vastly different. So, for me as a mother, as an activist, as a midwife who is now providing that care to people, I can say that we're here for our rights. We're here to change the medical industrial complex. And because midwife-centered care really works, midwife means with woman, although midwife can be with people, not just with women. Midwives are the experts in healthy pregnancy and physiologic birth, which is what we want to center, right? We want to center healthy pregnancies, and we want to center physiologic births. We want babies to be born vaginally because we know it's healthier for the birthing person and for the baby in most cases, right? We want people to understand the importance of education, of health, of nutrition, of healing, of autonomy, right? And we want that culturally centered care to be valued, because it's such a rich history. And so much of the way that we understand healing and wholeness has to do with our culture and what our grandmothers taught us and what gets passed down, those ancient technologies that are full of wisdom. And that is so much being disregarded in the healthcare system that we are really, having to reclaim it and like excavate kind of and find, well, how did ancient midwives do this? Or, how do we heal from this without being so invasive, right? How do we facilitate vaginal births without using medications that sometimes don't work? How do we facilitate birth without using C-sections, right? And
Yeah.
we have these answers. We know based on research and evidence that, for example, one of the things I teach in my physiologic birth workshops in hospitals that I teach to residents and physicians is that gravity is free, right? We're just not doing enough of it in birthing hospitals. Like we're not getting people up and out of the bed. We're not making sure that they can squat and get on all fours and utilize different labor positions. Now, some hospitals are doing this, but for example, I live in Miami, in a Miami-Dade County, where the C-section rate is 50%. And that has a lot to do with the way that birth is facilitated. 1 out of 2 people are having C-sections. What does that do to a community? What does that do to a generation? What does that do to the next generation? But we have the answers. And so that's why we're advocating so hard. And it's not just a matter of saying like, we know the solutions. It's a matter of having to fight our way through the door to even talk to the decision makers, to even say, we have the solutions. Will you sit and listen to the people in your community who don't want to be cut open, who can give birth, who want to be able to trust their bodies? And we can do this. We have the wisdom to do it. We have the answers to do it. It's just a matter of the power ceding to the people.
Well, I just want to acknowledge that you dropped a bar there when you said gravity is free. And you can put that on a poster, tweet it, talk about it wherever you want to. That was fantastic. Leseliey, add on here because I know you have some value in this same context.
I would just add that having our babies arrive here alive should be the least of what we expect.
Wow.
Right? Not dying,
Yeah.
not being irrevocably harmed after birth should be the least of what we expect. When we dreamed Birth Detroit, we envisioned a world where birth is safe, sacred, and loving and celebrated for everyone, right?
Mm,
And
mm,
we've lost so much about the ceremonial and social nature of birth by anchoring it in hospitals with physicians. And a quick story I'll share is that when we opened our first neighborhood-based midwifery clinic in Detroit, we had some physician colleagues come tour and learn about the care we were providing. At the end of the tour, one of them, who had recently had her own baby, sat and cried. And
wow.
she sat and cried because she said, I am a physician with an abundance of resources and opportunity, and I did not have this kind of gentle care for my birth. Right? She
Mm,
was struck by how much time is spent with our families in prenatal visits. She was struck by how accessible our midwives were to our clients during their pregnancies. She was struck by the fact that our midwives visit our families in home within 24 to 72 hours after delivery, that they have support with breastfeeding, that they have emotional support, that we surround them with love and we tell them we love them,
mm, mm,
right? And
mm.
so all folks should have the opportunity to give birth with midwives in a community birth center designed in response to the hopes and dreams and needs of the community they live in.
Yeah.
And that can happen, and it can happen for a lot less resources than the system we are invested in today.
Wow. Thank you. Thank you for that. I got a couple more questions I want to get to you. Some really practical questions to help people who might be participating today and they're on their journey as an organization somewhere. I want to give them some practical help. But before we do that, I want to put a poll question up. We're going to pause this conversation and we want to know if you're planning to stay for the breakout groups. Of course, we hope you all will stay to share and participate, but we need your help in helping to plan whether we continue to, how we do the breakout groups. We need a sense of the crowd. So if you plan to stay for the breakout groups, just check yes. If you don't, just check no, no harm, no foul. And remember that if you have questions for the panelists, please continue to add them into the chat. We want to add those into the chat. So we'll give you a chance now to answer the poll. And then once the poll is answered, we'll pull that down. And I want to jump into this discussion a little bit more about a couple things. So I want to go three ways, and so we're going to start from a community-based standpoint, and then from a hospital state space standpoint. Is I would like to get your perspective about the potential partnership opportunities between community organizations and hospital systems. And so when I say community organizations, birth center, or maybe it's a local nonprofit who notices and sees the challenge around birth outcomes in their community. So how can systems effectively integrate and collaborate with community-based organizations or community doulas and midwives to improve maternal health outcomes? And Jamarah, I want to start with you with that question.
Thank you for the question. So in South Florida, we have the Miami Birth Justice Initiative, and we have a collaborative called the Black Maternal Infant Health Equity Collaborative. Now, I will say that when we started the collaborative a couple of years ago, we did start with a hospital as part of the collaborative. And that was Jackson Health System, which is one of the largest public hospital systems in the country. However, the hospital left the collaborative, but we are still working toward the same goals. So we have a birth center, Magnolia Birth House. We have Southern Birth Justice Network, and we have Metro Mommy Agency, which is a doula agency. So we have, three main organizations, plus we're partnered with the YWCA and an organization called Green Cars for Kids, which helps with transportation. And so what we're working towards is developing solutions and networks to really surround birthing people in our community. We're working on establishing research that demonstrates that when people have access to midwives and doulas, and when they have that continuity of wraparound care, which is some of the services that YWCA provides, for example, and also when they can access all of their birth options, when they're educated about their birthing rights, when they have a doula that is either covered by insurance or low cost sliding scale, that their birth outcomes are going to be better because there's going to be more follow-up care. There's going to be home visits. There's going to be calls. There's going to be someone they can access by text or phone call. There's going to be someone that can ask questions or get a second opinion. They can understand their rights through the Birth Justice Bill of Rights, right? All of these things help to prepare them before they go into the hospital to give birth. So we are seeing better vaginal birth rates. For example, we did a short-term data collection for 3 months, and it showed that our doulas had, in a county with a 50% C-section rate, had an 85% vaginal birth rate.
Wow.
So it was an immediate impact just from having the doula in the room. So we know that it makes a difference, and we're working towards, building this collaborative and hopefully replicating it so that it can, extend into other areas. Also, the collaboration. So we have in Miami our mobile midwife clinic, where we've converted an RV into a clinic, and we collaborate very closely with physicians. So I don't want to present a situation where it's like midwives and doctors are these adversaries. We work with many physicians that are supportive of midwives, and actually we need doctors. We need doctors because we have high-risk clients, because we need, opinions on things that are outside of the midwifery scope of care. In Florida, if someone wants to have a VBAC at home, they need a physician to sign off on that, right? I saw someone ask in the chat about age. They need a physician to sign off if they are over 40 years old, right? So there's things that we need to collaborate with physicians on. And so we really need doctors, and, shout out to any medical residents that are thinking about getting into OB care. Please collaborate with the midwives in your community, because the best outcomes are when midwives and doulas and doctors and all perinatal health providers can work together and collaborate together. And so when we do the workshops working with the hospitals, we talk about recognizing the innate power that each client brings when they walk into a space, recognizing the connection of every family member that comes into that clinical care setting. For many people, they're looking for a sacred experience, right? Whether that is a prenatal visit or whether that's a postpartum visit or whether that's the day of birth. This is about the sacredness of ourselves, our bodies, and our babies, right? We want to strive to support informed decision making and helping people take responsibility for their well-being, which means asking them about their history, asking them what are their family remedies and traditions, and incorporating that into their care, recognizing their culture and incorporating that into their care. Of course, making sure that they're involved in every decision so that they, it's a shared decision-making process, and using medical intervention only as necessary and only with consent. And making sure that, we're not just looking at clinical observations or just looking at people as numbers, but also thinking about intuition and, spirituality, and especially when those are values of the client, right? That those are components of the competency of decision making and the continuity of care throughout the childbearing year and cycle. That all of that is important to families, not just to be looked at as a body, but to be looked at as a whole person and as a whole family. And I would also encourage that, what we call normal, it varies. It varies from person to person. It varies across cultures. It varies across so many factors that, and we know a lot of the research isn't based on Black and Brown people. It's based on, the typical person, which in science has been white people. And so when we want to think about, oh, well, this is not normal, right? We have to look at, those cultural factors as well. And I think, being transparent about what is your childbirth philosophy and what are the rights associated with giving birth. I mentioned gravity, using gravity and movement, using a family-centered approach, and involving your clients as active participants. Like these should just be the basic standards. And if we shift the culture of healthcare in that direction, we're going to see a shift in outcomes and also in patient satisfaction as well.
Fantastic. Thank you for that. Leslie, what are your thoughts on collaboration?
I think collaboration begins with authentic and respectful relationship building
Mm,
across credentials.
mm,
So I'll say from a local perspective, at Birth Detroit, we've enjoyed very good relationships with our health system partners. And I think in part because we had some of those relationships before we started building a birth center. So
mm,
one of my co-founders was the director of midwifery at a local health system. I
mm,
was deputy director of public health. And so we enjoyed a level of, I think, credibility and respect that not all birth center owners automatically have, right? But we built those relationships and we have good partnerships in support of our birth center, in support of our families, in collaboration between the midwives and maternal fetal medicine, even in how we ran emergency drills before the birth center even opened. That
mm,
was a collaboration and a partnership. We also have at the local level a regional planning effort, Southeast Michigan Regional Planning for Birth Center Innovation or Integration, that brings together health systems, birth center leaders, payers, and also our local public health departments to talk about how we can better integrate and expand midwifery-led care in our region. And then on the national level, I would offer that as birth center equity, we see collaboration as critical. And
mm,
so we actually do some work with primary maternity care. They have published a guide for hospital integration in birth centers. And we also help facilitate public-private partnerships to increase access to birth center care and are working with a couple counties to help them do that. And so I think it's very important. And if there's a desire to do it, there is support to do it.
wow. Well, thank you. That's powerful. Chanel, what types of policy? Actually, before we get to the policy, I really wanted to ask you all this, and Chanel, I'm gonna come back to you. Go to you first on this one. Let's say I am a health system who doesn't have a relationship in the community. We didn't build a connection with the public health or any other kind of context, but we recognize that we're not doing it right, that we need to be better. We need partnership in the community to get to better birth outcomes, not just for the sake of birth outcomes, what's accountable to the hospital, but for delivering an equitable experience and getting to what a person who's giving birth wants. Where would a hospital start if I'm not in Miami or not in Detroit or I'm in the middle of Northwest Kansas and I want to be better about this? What advice or practical framework would you say to a leader in a hospital to start this kind of conversation?
I mean, I definitely would say start with reaching out to community-based organizations that have had a long-standing history within those respective communities, right? Unfortunately, I think many of us know that those situations have happened time and time again, right? Where there's initiative that is put forth by a hospital-based institution that, has said the initiative is towards the community and really like boosting people's accessibility, et cetera, et cetera. And then community comes and says, we don't want to utilize this. This is completely harmful. Like, I don't know who decided to do all of this. So I'm going to put my other hat on. At Ancient Song, we developed a in-hospital community-based doula program. And we did that with the intention of, one, making sure that community was at the forefront. Now, this is in a community where Queens, New York, it is a densely populated area of South Asian individuals. So a South Asian, Asian, and Hispanic population. And so with that, we understood that we had to be super intentional about reaching out to those communities first, right? So we created a community advisory board that encompassed community-based organizations that were there in the community and had longstanding relationships, so that we could come together and we could co-create and design what not a reactionary program would be, but what a responsive program would be in being able to serve those specific communities. We also trained the providers that were going to be working with anyone who was pregnant. So anyone who came in contact with someone who was pregnant or parenting, whether you were an admissions counselor, if you were a social worker, if you were L&D nurse, physician, residents, everyone had to be trained in understanding like a birth justice framework, understanding reproductive justice framework. They also had to understand the role of a doula. Oftentimes, people just throw doulas into a space and say, go ahead, work, do your thing, use your aromatherapy and rub some backs and everything's going to be okay. And it's like, no, that's not how it works. You know what I mean? Like there's a whole way to mitigate tensions before they could possibly arise, right? And a lot of that is having soft introductions where you could talk about, have you had any previous experiences, that may have put a sour taste in your mouth? Okay, how can we work towards creating better relationship building, right? A wraparound or feedback loops. So we did that. And then we trained people who live within the community. So it wasn't about Ancient Song who, anybody you can come and you can get trained, doesn't matter what community you're from. But we wanted people that were specifically from those communities who spoke Mandarin, who spoke Urdu, who spoke Spanish, who are going to be there so that they could be the ones who are providing the care to their community members, because those were trusted allies, right? Those were trusted advocates. And, it has, it's worked, right? There's we have evidence to show that it works. So I would say, it all starts with a conversation. It all starts with a level of intentionality. And a lot of it, depending on what the longstanding relationship has been in the community, it may be a little hard. Right. And there may have to be, conversations around what is the word I'm looking for? Reconciliation. And what does reconciliation look like, right? In meaningful ways. How do we create shared values around what it means to provide healthcare and to receive healthcare within the community? Because that's important. What does it mean for people's ancient technologies? And when I say that, honoring the midwife, honoring the community doula who hasn't had the training, but in the, the community that they were from, they're here now and they've been connecting and providing the resources for those, and them being able to be in that space and be respected. by others, honoring the mothers, and the grandmothers and the aunties and everyone else who, is contributing to the birthing experience. So again, I think it's just around a conversation around just a level of intentionality, you know what I mean, and a willingness to be uncomfortable, because there may be some uncomfortable conversations that happen, but in the long, the at the end of the game, the community is who benefits, and the hospital benefits, right? Because a good name
Yeah.
is better than gold.
Yes.
People
Absolutely.
like I think birth worker, midwife, everybody knows, like, you get the people who come to you is because most times it's because of word of mouth. It is
Yeah.
how you treated them, right?
Yeah.
How you made them feel. And how you made them feel has a lasting impression, not just for that birthing experience and that episode of pregnancy, but also like how you see yourself while you're in the postpartum period. You know
Yeah.
what I mean? Like, I don't think a lot of people really understand that. Like, I honor midwives. I met Jamarah when I first started my journey, and had an infant, you know what I mean? Like,
Mm.
strapped to my
Mm.
chest. So,
Mm.
we've known each other for years, and my children are now big now, right?
Mm.
It was midwives who guided me, as a parent through my journey into parenthood. It is midwives who ushered in the education around policy. It is midwives who ushered in the education around what does a community care network and framework look like. And so it's those same midwives who, like, they're more than midwives. And I think people need to really understand that. I think, we talk about it in the context of just maternal health, but they're advocates. They are, they are solution based. They are, and doulas, we help to just be the extra added, spice and seasoning to
Mm.
to what it is to what it is that they do every day. You know what I mean?
Yeah.
But it's also that intentionality around collaborative care framework. I've never met personally, I'm not saying it doesn't happen, but I've never met personally a midwife who has completely been like, I'm not working with these folks. I have no interest in doing,
Mm.
these things. Because they know the power of collaboration. They know the power of continuity of care. They know the power of showing up and what it means to see children come into the world, but also to support people in rearing those children, right? As
Yeah.
they go through their parenting journey. So yeah, it all starts with a conversation at the end of the day.
Well, Well, I will say, one, I appreciate you breaking that down because sometimes organizations have paralysis by analysis. They think that they have to have all the things lined up and all of the I's dotted and all the T's crossed before they can have a conversation. And what you've just framed up is just being intentional about asking for help, being interested to learn, and wanting to get to a solution by starting with a conversation. And I think that's a place that so many organizations feel like they're paralyzed and can't do. And you've just given a very clear, simple roadmap for how they can do that. Let me just say, I'm grateful for this conversation, and I know I speak on behalf of everyone. It's been powerful to have you here. We could do this all day. There's so many more questions I want to ask because I kind of glazed over my wife's birthing experience. It was not at all good, and I wish I would have had a Bill of Rights, or we would have had a Bill of Rights that we knew existed before we went into that hospital system, but we didn't. But now we all can be better for it because of the conversation and because of each of you. So I'm really grateful for you being here. And so I want to just say thank you to you, Chanel, Jamarah, Leslie. You all are wonderful and powerful as I knew you would be. I really appreciate you being here with us today. And for all of you who are watching and have joined us, we hope that you'll stay connected to the intersection. Please feel free to sign up for updates at meetattheintersection.org. Please follow our LinkedIn page and definitely do not forget to subscribe to our podcast on Apple, Spotify, Amazon, or wherever you listen. We really want you to give us some feedback and on our events and what we're doing here. And finally, we invite you all to stay for the breakout groups. If you can stay for the breakout groups, we want you to stay. If you're not staying for the breakout groups, we ask that you exit promptly so we know how many breakouts to set up and how many participants to expect. And we'll transition to those breakout groups in just a moment. But I want to thank you all for being here for this powerful conversation, reproductive justice in action, and what we all can be doing to build a better organization. So I thank you all, and we'll see you on the other side.